Management of diabetic ketoacidosis includes 6 or 7 headings. First is the quick initial assessment. So we can assess the breathing, airway circulation, and admit the patient to ICU. Second is fluid replacement. We know that there is a loss of 3 to 6 liters in DKA. So initially we have to give 1 to 2 liters rapidly as IV. Later oral fluids can be given. But one thing to be noted is if the patient can drink as orally fluids in the oral form, it can be preferred. Third heading is the correction of hypoglycemia, which is a common 2-mark question. IV insulin infusion is the drug of choice or the method of choice, treatment of choice. Initial bolus of 0.15 units per kilogram is given, followed by a continuous bolus of 0.15 units per kilogram per hour, which in an average is 5 to 7 units. Blood glucose monitored every hour. In the first hour, 50 to 75 milligram per deciliter reduction is needed. If it is not attained, that rate is not attained, we have to check the hydration status and double the insulin infusion every 2 hours until steady 50 to 75 milligram per deciliter per hour rate is attained. So when it reaches, the blood glucose reaches 20 to 50 milligram per deciliter, decrease the insulin infusion to 0.05 to 0.1 units per kilogram per hour. So that is roughly around 3 to 6 units. We have to start dextrose 5% alongside until the ketone bodies are cleared, because ketone bodies take time to clear from the body, and also to prevent the hypoglycemia in the stages of the treatment. Also, you have to monitor and take blood every 2 hours during the therapy to determine serum electrolytes, glucose and ketone body levels. So criteria for the resolution of DKA is blood glucose less than 200 milligram per deciliter, serum bicarbonate more than 18 milliequivalent per liter, venous pH more than 7.3. So these are the criteria for resolution. So typical duration of treatment is around 48 hours. Now coming to potassium replacement, it is simple. If the potassium is less than 3.3 milliequivalent, give 40 milliequivalent per liter. Give 40 milliequivalent per hour potassium. So it is in the form of 2/3 KCl, and that is potassium chloride, and 1/3 potassium phosphate. If the potassium is more than 3.3 but it is less than 5 milliequivalent, give 20 to 30 milliequivalent of potassium. If the potassium is more than 5, no need of giving any potassium. Hourly monitoring is just enough. Bicarbonate replacement, as if pH is less than 7, give sodium bicarbonate 50 to 100 ml IV infusion over 1 hour. Then the final thing is the treatment of precipitating event. Like if any infection is there, I have to give the antibiotics. Finally, coming to the complications of DKA, hypoglycemia, hypokalemia, MI, ARDS, that is acute respiratory distress syndrome, mucormycosis. Due to hyperglycemia and acidosis, mucormycosis can be seen in as a complication of DKA. Then cerebral edema in children. Then DIC, and finally acute circulatory failure.